I'm a physician scientist at the Children's Hospital of Philadelphia. My clinical practice is to care for children with rare diseases. So I'm a clinical geneticist that focuses mostly on children with inherited biochemical disorders or metabolic diseases. And on the other hat that I wear is I run a translational research lab, thinking about new ways to hopefully both understand what causes symptoms and the disease mechanisms in these diseases, but also really focused on developing new therapies, because I think we're at a really exciting time where the potential for genomic therapies or gene-based therapies is really on the near horizon. What needs to happen in order to make molecular therapies and genomic therapies a reality for these diseases? All the struggles that the families that I take care of go through. So time to diagnosis, ensuring an adequate diagnosis, understanding what's happening to their child. All of this information, it might seem clinical, and it is, and it's very important clinical work we can talk about, but understanding how that happens is essential to preparing to develop therapies. I try to integrate both the clinical work and the research work together because they really do inform each other in order to move things forward in a meaningful way.
Now, it sounds to me like that would be too many hats you're wearing at once. Or do you just have capacity that I just don't have in my brain?
It's a great question, and one my husband actually asks me on a regular basis. But I work with a lot of great colleagues that help sort of in all domains of my life. But I think that there is a special role for physician scientists who can live between these worlds in order to make those leaps, in order to actually make the connections between the clinical need and the exciting cutting edge research, to be able to communicate to the people in my lab and my collaborating labs, this is what the patients need. This is what I'm seeing when I walk across the street and see my patients in clinic. This is what we should be focusing on to really direct the attention. And then similarly, to take these research advances and bring them back to patients. And so, yeah, it's kind of crazy, but it makes sense most days, sort of living on this interface or this boundary between science and medicine. And I think it's really, I love doing it, but I think it's really important.
In very layman terms, talk about the MPS umbrella under which Sanfilippo falls a little bit.
What are all these words? So technically, you're right. I'm something called a metabolic physician, which is a type of physician many people have never heard of, just like most patients have not heard of these rare diseases. But what a metabolic physician is a clinical geneticist that cares for children that have, for some reason, have inherited a change that disrupts a biochemical pathway. Essentially, all it is the ability to break down certain things in your body and to use them, or to build certain things in your body and use them. And essentially, my field of medicine cares for the children that have inherited genetic changes that disrupt these biochemical pathways. In general, metabolic physicians care for children and people across the lifespan, right? So a lot of the diagnoses we manage, patients are diagnosed within the first week of life. So I see lots of babies that then we follow throughout the lifespan, but sometimes children are only diagnosed after a long diagnostic odyssey.
A kid like Connor gets diagnosed. We find out there's a lysosomal storage disease unit at CHOP. We come and you're sort of our main point of contact. What is your role in these children's lives in that capacity?
It varies a little bit from storage disease to storage disease, but in general, the lysosomal program, especially the MPS clinic here at CHOP, our role is to really integrate and think through the holistic care of patients with lysosomal storage disease. We are actively involved in the diagnosis in many children's cases, but let's say you come in with a diagnosis like your family. What we do is we make sure that we're thinking about all the different body systems or organ systems that can be affected by these diseases from head to toe, and that you're following with all the appropriate subspecialists, that we're anticipating any medical issues that might arise down the road with these diseases. And we're doing everything we can to optimize outcomes. So physical therapy, occupational therapy, organizing all of that to ensure that we're helping our patients lead the best lives that they possibly can. On the other side of that, it's really important to us to stay up to date with all of the clinical trials going on. And so we can make sure that when opportunities arise and if families are interested in considering research, that they're aware of those opportunities and help facilitate that. Those are some of the roles we play here. But we see kids regularly. It depends a little bit on if our patients have an enzyme replacement therapy available. We see them more often because they're coming in to get infused. But we see children in clinic, every 4 to 6 months. And we make sure that they're getting all the care that they need, both in terms of everything head to toe, but also learning support.
Another reason, I guess, for the regular checkups and with all these different specialists would be to essentially baseline to see where they are now and where they progress each year? I mean,
Yeah, and some children need interventions. It varies a little from MPS subtype to MPS subtype. But for example, even children with, let's say, MPS 2 that are on enzyme replacement therapy, we know that the enzyme replacement doesn't correct the bones. And so, unfortunately, many of our patients, as they get older into those teenage years, they have a lot of orthopedic complications, some of which require interventions like surgeries or bracing. And so helping families navigate at what point should I do X, Y, or Z, and making sure that they're getting the follow-up they need for that. Or you can have progressive cardiac disease and making sure they're being appropriately monitored and started on therapy when necessary for their cardiac disease. These are the types of features that we really think about. Because we don't focus on one body system or one organ, it's really our job to have no blinders and to think about everything from head to toe. I've taken care of a lot of patients for a decade now, and it's really nice to see them grow up. For most of the diseases that I care for, there are no cures at this point, but there are, for some of them, treatments that can improve the quality of life and help manage some of the symptoms, I would say. And I think that's going to change, but that's where we are right now in terms of metabolic medicine. Now, how does lysosomal storage diseases fit into this? So if you think about all metabolic diseases, right, all these inherited disorders of biochemistry, one subset of them are lysosomal storage diseases. And what a lysosomal storage disease is a disease that affects the biochemistry of a very particular part of the cell called the lysosome. It's not that important to know exactly what the lysosome does, but for big picture purposes, it's really important for breaking down and recycling things in your body. So when you can't break down and recycle things, stuff builds up. That's why storage is in the name of the diseases, right? So it's a lysosomal storage disorder because this sort of recycling or wastebasket part of the cell, the lysosome, doesn't work well. And then stuff builds up or becomes stored, and it leads to disease. Across all lysosomal storage diseases and the MPS disorders, which Sanfilippo is one of them, is again another subspecial little group of lysosomal storage diseases. About 2/3 of them affect the brain. So it's actually pretty common for lysosomal storage diseases across the board to affect the brain and have neurologic symptoms. Unfortunately, most of the patients with neurologic symptoms, it tends to be progressive because you have more stuff accumulating, more storage material building up in the brain. So amongst the MPS disorders, which, as I said, are just a little subgroup of lysosomal storage diseases, many actually do affect the brain. Many also affect the body in addition to the brain. And I'll say, honestly, in some subtypes, in some patients with Sanfilippo, you can definitely see features of the disease outside of the brain, but it's just unique with Sanfilippo, or I would say specific feature of Sanfilippo that the brain is the most affected.
There are lots of different solutions that are being implemented, stem cell replacement, genetic therapy. Could you talk a little about the difference between like a genetic therapy versus enzyme replacement in layman terms?
Yeah, in some ways, lysosomal storage diseases and the MPS disorders really have been at the forefront of targeted therapy development. These are really the pioneers in this space. And it started all with what's called enzyme replacement therapy. And this really was actually pioneered here and at the NIH in the 90s were the first approvals. And the idea here is that I told you that lysosome, so that thing that breaks stuff down, or that part of the cell that breaks down important waste material, is broken in lysosomal storage diseases. What an enzyme replacement therapy does is it basically gives back the protein or the little machine that can't break down the storage accumulation, right? So it sort of replaces the protein that is missing in order to break down all that stuff that's building up. Is very effective for certain lysosomal storage diseases. And I will say, in terms of what's approved right now, the vast majority of the enzyme replacement therapies that are approved affect things outside of the brain. Let's say they have MPS 2 or MPS 1, and they're going to start their enzyme replacement therapy. They will get an IV medication on a regular basis, so every 1 to 2 weeks, depending on the disease. And that IV medication gives back that little machine or that little protein that allows basically for clearance of some of the storage material. And it works beautifully for a number of the symptoms of the disease. It, for the most part, does not affect certain hard to reach areas like the brain and the bones. But overall, these drugs have been really incredible options for a number of patients with lysosomal storage diseases.
Think about it as like replacing a broken vacuum cleaner.
Yes. Yes, absolutely. It's like replacing the broken vacuum cleaner. That's a good analogy. Or a specific garbage disposal, if you're going to think about it, right? So all that stuff building up that you don't want there anymore, it's going to help process and move through the pipeline. And so because we know from patients that giving back an enzyme into the blood can fix certain features of disease, people thought, well, wouldn't it be wonderful if we could give back that enzyme everywhere in the body, including the hard to reach places like the brain? And if we didn't have to give it on a regular basis as an IV medication or as a regular infusion. So how can you permanently give back that missing important molecule, missing important protein? And so that is where the idea of gene therapy or molecular therapies have come into play for lysosomal storage diseases. In all honesty, the number of programs being developed in this space is huge because we know what the defect is in these disorders molecularly, like we know what's broken. And we know that if we put back the protein, you fix at least a lot of symptoms of the disease. So it's a logical next step to say, okay, how do I correct the gene or give back a gene to basically be a form of enzyme replacement therapy in some ways in order to try to fix the problem? And so that is why gene therapy has become so attractive of a possibility for these disorders. Now, gene therapy by no means is perfect, and everyone is working to make it better, but that's at least the theoretical framework behind which a lot of people are going after this.
Okay, just back up one sec. So we were talking about enzyme replacement therapy, sort of dropping a good one into the thing.
Yeah.
Term gene therapy, what is the difference there?
It's a great question. So enzyme replacement therapy, you're actually giving back the protein. So right in your cells, in order to make a protein, the instructions for making that protein or that little machine that does the work comes from your genes. Okay. So in the case of enzyme replacement therapy, they're actually giving back the machine. In the case of gene therapy, you're giving back the instructions to make that machine or make that protein. That's what the gene is. And so the goal is to permanently give back the instructions to the cells of the body to make that little machine or that protein to do the work. And so it's a more permanent solution as opposed to enzyme replacement therapy, where you just have to keep giving back the machine because it gets broken down over time. So for enzyme replacement therapy, let's say you get your infusion on a Monday, by the following Monday, if you check the blood levels, the actual amount of that enzyme around is very low because your body naturally clears it. But if you have the instructions permanently in your cells to make that protein, you'll always have some degree of that protein around. And so that's really the goal, is a more permanent solution where you don't need repeated infusions, and ideally a permanent solution in cell types that have been hard to treat with enzyme replacement therapy alone.
There have been some genetic therapy clinical trials for Sanfilippo. For my kids, specifically type C, there has not been yet.
Correct.
Of the A and B types where there have been clinical trials, the first thing that comes to mind is the money. Funding is always a huge problem in Sanfilippo world because the population's so small. What have been some of the challenges that have prevented major progress in these potential solutions?
What I'm going to speak to here actually applies to a lot of rare neurogenetic disorders and neurometabolic disorders. I think Sanfilippo has taught us a lot of these lessons because of the trials that have been tried in this group. I think the most important thing that I've taken away from the trials, and something that the community as a whole has worked so hard to do, is that for any disease in a rare disease population where you're trying to show that your drug, your gene therapy, whatever it is, works, you have to understand the disease first. You need what's called natural history data, and that is crucial in the rare disease space. I think in Sanfilippo, one of the things there's been so many amazing efforts to define natural history, which we can speak about, but it's really a hard thing to quantify. So what natural history is basically what happens, or what's the typical course of progression of these diseases in kids or patients. So, at what age do most children with Sanfilippo learn to talk and walk? And then what happens after that? So understanding what normally happens, what the natural progression is of the diseases, and what the variability is in that. Because there are absolutely children who are more severely affected early on, and some children who have what we call attenuated forms that progress much later. And there's been a ton of work to try to define this for Sanfilippo. It's been beautiful data. And I will say that we have learned from the trials, having this data is so important, because unlike, let's say, developing a new drug for high blood pressure or developing a new drug for all these other more common, often adult onset conditions, most of these trials do not have a control arm. That's not true for everybody, but there's not a direct comparator at the same given time, right? That's in general for ultra rare pediatric diseases. That's not the way trials work because there just aren't enough patients out there. And so you have to compare how well your drug is working to what we think the typical progression of this disease is. And so you have to define that natural history. And that's been so important for Sanfilippo and for other rare diseases. And I will say what's hard for Sanfilippo is that the natural history data is essentially all what we call neurocognitive data. Those are the symptoms that we measure. So that is a child's ability to learn, a child's ability to do different cognitive tasks, functional tasks, all those measures of the brain. And that is very tricky to measure reliably in children over time. And it makes the endpoints or the things that show us that a drug works in Sanfilippo really difficult, because it's not just, does their liver get smaller or does their blood pressure go down for a blood pressure medication? It's what does their development look like relative to these natural history controls? It was more difficult to show robust differences because as a parent, as a physician, we all know there are days that our kids just don't want to participate in whatever testing is being done. And there's good days and bad days. And so anytime you have these endpoints that are so dependent on participation of a child are difficult to obtain, which is the things we measure in Sanfilippo, it makes it hard.
Could you talk a little about the unique challenges of delivering this type of gene therapy through the blood-brain barrier, I guess, which is unique to Sanfilippo because it's in the brain?
So this is a problem. It's especially important in Sanfilippo, but it's a problem we're facing across storage diseases of the brain in general. And it's not just the blood-brain barrier. It's actually getting that instruction into the right cells at the right amount in the brain is actually very difficult. So there's multiple layers of obstruction or multiple obstacles you have to overcome. So the way we give back a gene, there's actually people trying to develop many new ways to give back a gene, but traditionally you give it back using what's called a viral vector. So the idea is you take a virus, you take out all the stuff that can make you sick, and you put in that gene or that instruction of interest that you really want to be present in the cells. And then you give that virus or that viral vector to a patient, and that instruction is essentially put into the cells using that viral vector. In general, most of the viral vectors that we have, if you give them into the blood, you're exactly right. They don't cross the blood-brain barrier. That virus doesn't get into the brain compartment, which is so important to correct in lysosomal storage diseases. So giving a virus into the blood doesn't tend to fix the brain.
Is there not blood in the brain?
There is, but there's something, as you mentioned, called the blood-brain barrier, such that specific stuff essentially doesn't cross over, because you wouldn't want everything in your bloodstream to be exposed to your brain. Like you wouldn't want your brain to see everything that's in your bloodstream. And so we have this very sophisticated blood-brain barrier that acts sort of as a blockade between those two compartments. And viral vectors in general do not cross the blood-brain barrier. But it's even more complicated than that. Let's say you can get the virus into the fluid around the brain, for example, the cerebral spinal fluid. What we're learning, and then we can talk about ways people are trying to do that, which is great. What we're learning is that these viruses don't necessarily infect every cell in the brain. And for some diseases, it's really important to have widespread correction of this biochemical difference throughout all cell types of the brain. I should step back and say, okay, so getting across the blood-brain barrier is hard. So there are trials going on now of people giving these viral vectors directly into the fluid that surrounds the brain. So you do it into the cerebral spinal fluid, either through a space at the bottom of your back, sort of like an epidural when you're, undergoing childbirth, similar procedure, or into a little space at the base of the neck, where this viral vector, this thing that carries the gene that is a functional gene copy, goes directly in the cerebral spinal fluid. And the thought is that gets you closer to correcting all of those important cells of your brain. And there's ongoing trials for that, and it's been shown to work in animal models. And so that is one approach people are taking. And then the other approach in terms of viral vectors in the brain is people are trying to develop viral vectors that do a better job of correcting cells in the brain. So it's getting across the blood-brain barrier and then getting the virus or the vector into the cells you actually need to fix.
Theoretically, I would think it would be doable or potentially possible to just go directly into the brain somehow. Does that make any sense or no?
Yeah, so people have tried that, and there have been trials of this. And so what I spoke about in terms of the cerebral spinal fluid, the idea there is that fluid bathes the brain. And so you're going to contact a lot of parts of the brain. You're right. People have tried direct injection into the brain. Unfortunately, for some diseases where you need widespread correction in all parts of the brain, when you do direct injection into the brain, that virus actually doesn't spread that far. So you need to inject a lot of different places in the brain, which can become problematic. Now, there's some beautiful data out there for genetic diseases where if you correct one specific part of the brain, you fix the disease. And for those types of diseases where you only need to fix one little region of the brain, that might be a great idea because you can inject your virus, you get enough locally. But if you need widespread correction of the entire brain, direct injection is, I'll be honest, is hard. People are working on it, but it's hard.
What have been some of the challenges that have prevented major progress in these potential solutions?
What I'm going to speak to here actually applies to a lot of rare neurogenetic disorders and neurometabolic disorders. I think Sanfilippo has taught us a lot of these lessons because of the trials that have been tried in this group. I think the most important thing that I've taken away from the trials and something that the community as a whole has worked so hard to do is that for any disease in a rare disease population where you're trying to show that your drug, your gene therapy, whatever it is, works, you have to understand the disease first. You need what's called natural history data, and that is crucial in the rare disease space. And I think in Sanfilippo, one of the things that, there's been so many amazing efforts to define natural history, which we can speak about, but it's really a hard thing to quantify. So what natural history is basically what happens or what's the typical course of progression of these diseases in kids or patients. So, at what age do most children with Sanfilippo learn to talk and walk? And then what happens after that? So understanding what normally happens, what the natural progression is of the diseases and what the variability is in that, because there are absolutely children who are more severely affected early on and some children who have what we call attenuated forms that progress much later. And there's been a ton of work to try to define this for Sanfilippo. It's been beautiful data. And I will say that we have learned from the trials, having this data is so important because unlike, let's say, developing a new drug for high blood pressure or developing a new drug for all these other more common, often adult onset conditions, most of these trials do not have a control arm. That's not true for everybody, but there's not a direct comparator at the same given time, right? That's in general for ultra rare pediatric diseases, that's not the way trials work because there just aren't enough patients out there. And so you have to compare how well your drug is working to what we think the typical progression of this disease is. And so you have to define that natural history. And that's been so important for Sanfilippo and for other rare diseases. And I will say what's hard for Sanfilippo is that the natural history data is essentially all what we call neurocognitive data. Those are the symptoms that we measure. So that is a child's ability to learn, a child's ability to do different cognitive tasks, functional tasks, all those measures of the brain. And that is very tricky to measure reliably in children over time. And it makes the endpoints or the things that show us that a drug works in Sanfilippo really difficult because it's not just, does their liver get smaller or does their blood pressure go down for a blood pressure medication? It's what does their development look like relative to these natural history controls? It is more difficult to show robust differences because as a parent, as a physician, we all know there are days that our kids just don't want to participate in whatever testing is being done. And there's good days and bad days. And so anytime you have these endpoints that are so dependent on participation of a child are difficult to obtain, which is the things we measure in Sanfilippo, it makes it hard.